Hello, my name is Laetitia and I am a nuclear medicine technologist at Monash Health in Victoria. So my aim today is to demonstrate the value of 18F-FET and 18F-FDG as a tool in the diagnosis and grading of gliomas where MRI is contraindicated, as well as to contribute to evidence-based medicine that may improve the overall clinical management of patients with neuro-oncological disease. Gliomas are brain tumours that originate from glial cells of the brain and the nervous system. They are presently a leading cause of cancer mortality in adults, representing about 28% of all tumours. These tumours can be classified as either low-grade or high-grade depending on the type of glial cell involved, as well as the tumour's genetic features. So the current gold standard for investigation as well as tumour imaging is MRI. However, not every patient is suitable to undergo this imaging modality because of various contraindications. Developments in PET imaging have been able to offer an alternative and non-invasive means to achieving a timely diagnosis that is integral to the clinical management of patients. So the traces we will be focusing on today will be 18F-FET and 18F-FDG. FET is a fluoride-labeled amino acid tracer and is taken up by tumour cells because of the overexpression of amino acid transporters. Many studies have been published showcasing FET's value in being able to distinguish between recurrence of tumour, pseudoprogression, and radiation necrosis. FDG, on the other hand, is a glucose analogue and is metabolized in a similar way that glucose is in the body. FDG is very well established in the diagnosis of systemic oncology and has demonstrated prognostic value in identifying anaplastic transformation of high-grade tumours that were previously known to be low-grade. So the patient was an 83-year-old male who presented to the hospital with intermittent episodes of confusion, short-term memory disturbance, unsteadiness, and a vague headache. He was initially referred for a CT scan of the brain, which showed a temporal lobe mass with significant edema and midline shift. This was followed by a CT perfusion study that showed perfusion abnormality. This made it quite difficult to discern whether the patient's clinical presentation was a result of a stroke or an underlying mass. So because the patient had a pacemaker in situ, MRI was contraindicated, and so the patient was referred to the PET department for further investigation in order to clarify his underlying pathology. The first study we performed was an 18F-FET. So 273 megabecquerels of 18F-FET was administered intravenously with a 40-minute dynamic image acquired directly after. The imaging parameters are as displayed. So these are the pictures that were extracted from the dynamic series. The findings displayed a FET-avid large right temporal lobe mass that measured up to about 8 centimeters, which were consistent with the recent CT findings. As you can see, the tumour to background ratio is quite high. This is also another reason why the study is quite appealing to clinicians, as the image quality allows for quite simple interpretation. So alongside the images, another value of FET imaging is its ability to generate time activity curves from the mean tissue radioactivity in the tumour. So in the case of this patient, you can see the activity peaks early on and then plateaus over time. This presentation is typically indicative of a grade 3 and 4 tumour. Now, while suspicions were raised that this tumour was of high-grade nature, a pitfall of FET is that it's unable to actually differentiate between high-grade and low-grade tumours because a high proportion of low-grade tumours are also active in malignant transformation, meaning it all lights up. So this leads us onto our FDG study. The next objective was to establish firstly how much of the tumour was high grade, and secondly to confirm whether there was any widespread metabolically active disease elsewhere in the patient's body. At this point, a follow-up CT had also been performed and a differential diagnosis of lymphoma was actually favoured. So to perform this study, 260 megabecs of 18F-FDG was intravenously injected into the patient. A dedicated brain and whole body image was then acquired. So these were the dedicated brain imaging parameters and the whole body imaging parameters. So purely assessing the findings from this study, you can see evidence of FDG avid disease in the right fusiform gyrus with no extracranial FDG avid nodal or extranodal disease. Based on these images alone, determining whether the tumour is purely high grade or a combination of both isn't feasible because the uptake of low grade tumours is typically similar to that of normal white matter in FDG imaging. Now, conversely, when compared against the FET images, this characteristic uptake of FDG allows us to discern which part of the tumour is high and low grade. You can see when the images are placed side by side that the FDG hypermetabolism is seen in a smaller area contained within the previous FET avid lesion. From this, an accurate target for biopsy was able to be identified. So following the study, a biopsy of the FDG avid site was then performed by the neurosurgical team. The resulting differential was high-grade glioma. So due to contraindications for MRI, PET was particularly useful in this case. FET was used to differentiate between non-malignant and malignant cause, whilst FDG was used to determine an accurate target for biopsy and to discredit differential theories including CNS lymphoma. So this case study demonstrates significant value of both using FDG and FET as a diagnostic duo in investigating patients with neuro-oncological disease who are contraindicated for MRI. Just in the last half decade, the Response Assessment in Neuro-Oncology Working Group has recommended the use for PET in addition to MRI for brain tumour management. This case study was a really good example of why and how PET studies are making an impression in the neuro-oncology world. A definitive diagnosis is integral in the clinical management of patients. The double tracer approach in PET has significant diagnostic performance and can improve diagnostic accuracy, treatment management, and overall patient outcomes. Thank you.